Thank you very much again. Chronic renal disease is associated with increased morbidity and death after open abdominal aortic aneurysm repair. So for the purpose of this presentation, we analyze the impact of the EVAR on the postoperative renal function. All emergency procedures or thoracoabdominal repairs were excluded. We studied the postoperative results in 200 consecutive patients with AAA who were operated on between May 2008 to February 2013. All patients received a bifurcated endograft, and the results, no mortality was registered. In 169 patients, the renal function were normal before and after the procedure. Preoperative creatinine levels were almost the same like in the discharge, but 14% of the patients increased creatinine values more than 20%, but with no clinical significance. But more interesting was that no severe renal impairment was described related to nephrotoxicity, but 2% of the patients developed an acute renal failure due to renal artery occlusion. One patient was treated by PTA and stenting, 2 patients received an iliac to renal bypass, and 1 patient refused to be treated. ICU stay was 1.6 days, and total hospital stay was almost 2 days. Preoperative renal insufficiency was a positive predictor of prolonged hospital stay, and also 16% of the patients could not be evaluated, but contrast images during the mean follow-up of 22 months due to chronic renal insufficiency. So what can we do to avoid postoperative renal impairment? Well, one, correct preoperative planning, paying attention to the angulations, clock orientations of the visceral vessels, thrombus or calcification. Also, preoperative renal care means intravenous normal saline expansion, and also a combination of N-acetyl, cysteine, and bicarbonate. Also avoiding elastomeric balloon insufflations in patients that they don't need to do that. And for patients with good, means long proximal necks, the use of repositionable C3 excluder stent graft. But what can we do with patients with unsuitable proximal necks, means outside the IFU? FEVAR, chimneys, Palma stent, prophylactic annulations of the renals, flow diverters, open surgery. Which are the options for this type of patients? What is more frequent in your practice? What is more dangerous for the patient? What is more difficult to resolve? A type 1 endoleak or a unilateral renal artery occlusion? And those are related to planning problems, intraoperative problems, preoperative incorrect decision, because the endograft did what it wanted to do, but not what we wanted to do. So one option is FEVAR, fenestrated EVAR, is the most frequent reported of all these procedures, with high technical success rate, with low operative mortality, with excellent mid and long-term results. But in our cases, it took almost 3 months of waiting time, and costs are really very, very high. What about chimney? It's far less reported, with also high technical success rate, with an operative mortality rate from 0 to almost 15%, with excellent short and mid-term target vessels patency, but associated with increased proximal type endoleak, and its use seems only be favored in acute high surgical risk patients. In elective cases complicated with unintentional renal artery coverage, or in anatomies unsuitable for FEVAR. And what about the plan B? What about if we have a type 1 endoleak in patients with ischemia? So we have also two more options. EVAR, standard EVAR, but performed outside the IFU, means increased operative mortality and morbidity, increased rate of type 1 endoleak, and increased rate of migration. And what about flow diverters? No or contradicted evidence, and it's also contraindicated in ruptures. So in conclusion, proximal fixation type has no significant effect on both acute and chronic renal function. Embolization, thrombosis, and nephrotoxicity should be prevented. Identification of modifiable perioperative risk factors may be used to improve renal function outcomes. More aggressive strategies to monitor and preserve renal function after AAA repair are warranted, and custom-made or off-the-shelf fenestrated stent graft currently represent the most validated endovascular option for this type of patients. Thank you very much.
Obrigado, Dr. Mariano Ferreira.